دكتورة شيخ العبري صح دكتورة؟
ايوه
خليها تشوف الواتساب مالها دكتورة، رسلت لها اللينك.
نبدي زكية. يلا recording.
Yes.
Assalamu alaikum. Hello everyone. I would like to welcome all of you and thank you for taking the time to join us, especially during the weekend. I would like as well to welcome our guest speakers who kindly accepted the invitation and agreed to join us and to share their experts, especially with a topic which is very important to all obstetricians. We have arranged this webinar session because we have noticed that the number of cases and the number of complaints, especially those related to intrapartum or birth asphyxia, had increased during the last 2 years, and we thought that doing such CME activity may help us to improve our reading for the CTG and also to reduce such cases. Today's session is about the fetal monitoring in labor, and I hope all of you will enjoy all the topics. We try to cover almost all the things related to the CTG and to fetal monitoring in labor. The session will be moderated as well with my colleague, Dr. Ahlam, who is in charge of obstetric ultrasound unit at Royal Hospital. And we will start with the first speaker. I think the first speaker is well known to all of you, is Dr. Badriya Al-Fahdi, and she will talk more about the physiology of fetal monitoring in labor. Dr. Badriya, she was obstetric consultant, fetal-maternal at Royal Hospital, and now she's enjoying her career at the private sector. So Badriya, the floor is yours.
Good morning. Assalamu alaikum. First, I think I have to share the screen, or the screen is shared. It's shared. See, when Moza asked me to present this topic, I felt, oh my God, it's very boring topic, and how I can, you know, can make the presentation. And to me, I didn't enjoy till I started seriously preparing it. Now I'm looking for the slideshow, how to close this.
Start from beginning, Dr. Badriya, and slideshow.
It is slideshow already?
No, not yet, Badriya.
ترى هي المشكلة الزوم is covering my slideshow. How to close that Zoom? Thanks. في الميرور مال الزوم.
The pictures قصدك؟
لا مش picture. اللي تحت مكتوب mute, stop videos, participant. مغطية علي السلايد شو.
هناك share screen.
أيوة سوي أنا share screen. It is already shared صح؟
Click on the slide نفسها. Click on the PowerPoint, which should the Zoom part will disappear, and you'll get the share screen, the presenter view. فتحي الباوربوينت بدرية. It's not open yet.
Okay, open.
أيوة. Okay, نعم.
هي ترى هي دي الشاشة ما قادرة ألاقيها من تحت. يا ربي.
نزلي شوية.
أيوة. ما طلعت تقفل. أنزل بعدني. شوف هو هذا الباوربوينت. زين. الشاشة مالي.
انزل اطلع. سوي له كليك وينزل على تحت، ونزلي على تحت، سحبي.
استغفرك ربي. We close all windows, Prof. Zoom.
بدرية try F5
shift and F5 بدرية.
times F5 will start
Shift
like
and
so.
F5
Okay, shift
and F5
and F5 computer.
فوق.
ما عندي F5 صدقوا.
F5
أعرف الفانكشن لكن ما عندي F5 هنا. لحظة FTN أيوة أوكي. Yes.
okay.
ماشي لكن بعدين.
Apple your Mac ولا
إذا أقول ذكية أطلع وأدخل.
Mac ولا Windows بدرية؟
ذكية.
نعم دكتورة.
ألو. اسمعني ذكية.
أسمعش دكتورة، دخلي وطلعي مرة ثانية ماشي مشكلة.
انزل أطلع وأدخل. يلا باي.
Maybe I should start first.
Try again, Badriya, now.
أيوه. أوكي بسم الله. So when I started preparing my presentation, I thought it is an important topic because to know about anything, you should know how it starts. My topic is about maternal mechanism of fetal acidosis and assessment of central organ oxygenation. Though I like more the practical and the CTGs, but this is also an important topic. So as you know, fetal oxygenation depends on the adequate oxygenation from the mother, a healthy functioning placenta with adequate blood flow, and uterine blood flow from the mother, adequate umbilical circulation, and the baby, its own mechanism to regulate fetal heart rate response to the labor and other stresses, which is, I think, will be presented by Dr. Shitra and Dr. Geshri. That is, it will be within the hypoxia range. So, fetal acid base imbalance may occur it will occur if there is any interruption to blood flow to the uterus or across the placenta or through the umbilical cord. To the uterus if the mother has hemorrhage or maternal collapse, sometimes during epidural. So what happened during pregnancy? Actually, during pregnancy, the respiratory component of maternal acid-base system showed a progressive fall in the arterial CO2 tension and a rise in the oxygen tension. And that you know, these both changes cause a reduction in the plasma bicarbonate. This result in respiratory alkalosis and compensatory metabolic acidosis, which make the pH is normal. This allow alkaline side of, but in the alkaline side of the normal pH. This progressive fall in the CO2 of the maternal capillary and increase in the oxygen tension, it will make, you know, a difference in the, like a diffusion difference in pressure. And this increase with the trimester. So it will be easy for the baby to get rid of the CO2 to the mother and get in the oxygen from the mother. So the lowering of the maternal CO2 tension increases its transplacental gradients to about 8 to 10 millimercury, enabling that transfer or the transport from the fetus to the mother. So the fetus will develop in an environment with slightly lower than CO2 tension than what is slightly lower than that of the adults. So what you need to remember is the oxygen pathway. So this diagram explains it. The environment, then the mother lung, the oxygen pathway will go from the environment to the maternal lung, then the heart, maternal vasculature, then to the uterus, placenta, umbilical cord, and finally to the fetus. And then the fetal response, which you will get it within the rest of the lectures. So how the fetus adapt to all this? So the fetus has ability to extract oxygen greater than that of the mother, plus the fetal hemoglobin has higher affinity for oxygen and higher concentration. This is also, this will result in that the fetus has higher ability to carry more oxygen than the mother. One of the other mechanisms also that the fetal cardiac output is higher per unit of his weight compared to the adult. So the cardiac output compared to the fetus weight is higher. We will continue fetal hemostatic mechanism. Also, the fetus has more capillaries per unit of the tissue than adult. The fetus overperfuses some of its organ. Also, the fetus has preferential shunting to some of the organ, which is more important, like the brain, the myocardium, adrenal glands, via the ductus venosus, foramen ovary, and ductus arteriosus. So all these homeostatic mechanisms interact and influence the blood flow to promote oxygenation mainly and to protect vital organs. And that is what happened in labor when the baby, the fetus, I mean, will reduce blood supply to, even in IUGR actually, it will reduce blood supply to the unnecessary organs, like, you know, bowel, skin, and it will improve blood supply to the brain and to the heart, just to make sure that it is.
Dr. Badria, the voice is not very clear.
I was just checking that if you can hear me now?
Yes.
I was just checking the charger. So that is the two mainly, all the mechanisms work together to promote oxygenation and protect vital organs. These mechanisms provide reflexes response to both hypoxemic and non-hypoxemic stresses. And what I mean by non-hypoxemic stresses, like, you know, inflammatory responses like sepsis, is usually non-hypoxemic, but it will lead to the same end. So the physiological compensating mechanism of the fetus respond to hypoxemia, redistribution of blood flow to the vital organs, heart, brain, adrenal glands, and decreased total consumption. This is, I think, Dr. Shitra will go through also decreased total oxygen consumption by deceleration. You know, when we will go in the CTG, the variable deceleration, mainly it happens why? To reduce the consumption of the oxygen. So it is adaptory mechanism. It is not a bad thing. And that is, of course, depends on the organ. So the normal healthy fetus can withstand repeated transient hypoxemia from the uterine contraction. That is the way the God has created the fetus, and can maintain normal aerobic metabolism till O2 in the intervillus falls to about 50% of the normal level. And here it comes, you know, that is, we talk about the normal healthy growing fetus. That is, it comes when you look at the history, a chorioamnitis fetus, a fetus who is IUGR, a fetus of diabetic mother, all these, they cannot, you know, they cannot respond the same as the normal healthy one because their mechanisms are already affected somehow. So acid-base physiology is very simple thing. There are 3 types of acidemia: metabolic, respiratory, and mixed. So glucose is the main fuel used by the fetus for the energy. So what happened to the glucose usually? So the glucose will go into the, if it is, finally, the lactic acid is the final product. So if the oxygen is present, that is the slide, the diagram to the left, lactic acid gets converted to CO2, and large amount of energy produced, which was around 38, that is the ATPs, and then CO2 transferred across the placenta to be excreted by the mother. And I explained already at the beginning of the presentation that the mother CO2 is a bit lower than that of the fetus, so creating a gradient allowing the CO2 to be transferred. Imagine if it is hypoxic fetus, what will happen? Then lactic acid cannot be broken down to the CO2, and lactic acid gets accumulated. So, and actually the anaerobic one, it produces, as you know, this is all basic physiology, produces less energy. From the 38, which is produced in aerobic one, we get only 2 ATPs. Bismillah. So the hydrogen ions, my phone was ringing. Hydrogen ion get retained, and then it gets buffered by the bicarbonate, and finally we ended up with metabolic acidosis, decreased pH, normal BCO2, and low BO2. So anabolic metabolism, how it leads to metabolic acidosis by, I already explained that is in this slide, by accumulation of the lactic acid, building up of lactic acid within the tissue. Though the buffer system, primarily bicarbonate, used, it neutralizes the lactic acid, but it gets used up and the pH finally fall, leading to metabolic acidosis and cell death. So how we define metabolic acidemia? Metabolic acidemia is defined as abnormally high hydrogen in the blood. The more hydrogen ion there are, the more acidic in the blood and the lower pH. This is all, I think you know, it is just refreshment. What is a buffer system? The buffer bases, you know, when we do the cord blood, we call the acid deficit or base deficit. That is the amount of the base used to neutralize the pH. So if you reach a deficit of 15, this baby is already hypoxic. So buffer base is primarily bicarbonate utilized in the order to neutralize the acid. If the buffer are used, this is the same slide up here. So one of the things also, hypotension. So if there is hypotension, when there is acidosis, it will reach, the fetus will have also hypotension. This is, you cannot measure, but you can see in the CTG by recurrent deceleration. So then if there is hypotension, there will be tissue hypoxia and acidosis, and it will, you know, this is a vicious cycle. So if you don't improve the oxygenation, it will lead to hypotension. Then you will lose peripheral vascular smooth muscle contraction, reducing peripheral vascular resistance, and then the fetus will lose the autoregulation of cerebral blood flow, and then perfusion to the fetal brain becomes pressure dependent, and then brain will not receive adequate blood flow and become ischemic, and this is the end stage. So you'll have a brain death baby, or you'll have stillbirth. And this will lead to a fetal injury. So fetal acidemia and fetal hypotension, they lead to each other, risking cellular damage and injury. Fetal brain injury occurs as a result of decreased both oxygen and ischemia. So what important points we need to know? So even in the presence of significant acidemia, most of the newborn will be neurologically normal. And you know, we have seen many times a baby will born with bad Apgar, with cord pH 6.9, and they do very well, provided, depends on, you know, how much time they were exposed to that fetal hypoxia and how much damage they got. So the presence of metabolic acidemia does not define the timing of the onset of hypoxic ischemic event. And this is the things why you want to treat every fetus differently from the other. I don't say, okay, yesterday I delivered a baby who is pH 6.9 and he did well, so it's fine to deliver the babies this way. But most of them actually, they behave well, alhamdulillah. So now we'll explain what is respiratory acidemia and how the they interact together. So in respiratory acidemia, the same slide which I explained before. So what will happen? So if there is umbilical cord occlusion, there will be increase in CO2, and CO2 hydrolyzed in HCO2, and then it gets dissociated, and then we have bicarbonate as the end products. So this is respiratory acidosis. Respiratory acidosis, hypercapnia, and hypercarbia. It is an increase in the CO2 in the blood. Hypercapnia, increase in CO2 in the tissue. So when CO2 increases, the pH decrease and can occur with umbilical cord compression. And respiratory acidosis is usually get cleared fast. That is the thing when usually cord occlusion. If it didn't continue for a long time, it doesn't usually reach cause to ischemia. So usually what will happen, retention of CO2 and hydrogen. It is common with nuchal cord and does not damage the organ, and it shows in the CTG as variable deceleration and usually resolve very quickly. And it has very positive, after delivery, with positive pressure given by neonatologist, it improves very, very well. So mixed acidosis, it is when both respiratory and metabolic components are there. The mixed acidosis, you will have low pH, and this is good when you read the SCABU, the SCABU core pH. So the low pH, high BCO2 and low BO2, and high base deficit. So this is one of the when we send the core pH to the SCABU, this is how we read it. So if you have only respiratory acidosis, you will have, yes, low pH, but you will have elevated partial pressure of CO2, and base deficit is less than 12. These usually they recover very fast, and they have no neurological deficit. The second type, which is the metabolic, it's the worst one. When they have low pH, of course, because we said acidosis, they will have normal BCO2, and they will have base deficit, which is more than 12. And the mix, the only difference in the mix that they will have elevated BCO2 like in the respiratory, but at the same time, they will have a base deficit more than 12. And actually base deficit more than 12, this is indicate an acidosis, and usually they have bad outcome, especially if the action not taken on time. So outcomes, if it is respiratory, we said that Apgars improve readily with resuscitation, typically by 5 minutes. If it is metabolic, resolve slowly with resuscitation. There is one point with the metabolic. If the baby is already IUGR or a high-risk mother like diabetic or placental issues or anything, the resolvement or the improvement, it takes time compared to a normal baby. So we have to look at the entire clinical picture. We have to use clinical judgment and work as a team. So blood gases are biochemical component of the diagnosis. So what are umbilical cord blood gases that is after delivery? It reflects the oxygenation and acid base, because many times we have a fight with the SCABU actually, because we think that the baby, actually many times, even for me, if the baby doesn't have multi-organ damage, I will think, no, it wasn't my fault. We didn't deliver the baby late. The pediatrician always want to blame us. And many of us think that, and we are always, in a fight with the pediatrician, because each one will think that it is the fault of obstetrician or the fault of the pediatrician regarding the resuscitation. So the umbilical cord blood gas is one of the very important, and it is used as legal component against us, and of course. So it reflects oxygenation and acid-base status of the newborn at the time of delivery. It also reflects placental function and maternal status, and do not necessarily reflect the duration of the insult. So umbilical RTBH, it is usually, particularly the base deficit, we have to look at it, can provide an index of fetal acid base status at the time of delivery, but we don't know the damage happened when. And umbilical cord artery metabolic acidemia has a relatively weak predictive value for long-term complications, such as encephalopathy and cerebral palsy. This last thing is very important because, subhanallah, we have seen many babies with metabolic acidemia, but they have no neurological sequelae. So though it will show that the baby has, or the fetus has metabolic acidosis, but it will not predict the outcome. Of course, the worse is the metabolic acidosis, the worse is the outcome, the lower or the slower the improvement. So now I will explain steps for interpreting the blood gases. Step 1, is the sample venous or arterial? As you know, the venous tells you about what was coming to the baby from the mother, because the venous, the umbilical vein, it will carry the oxygenated blood from the mother to the baby, while the artery, the opposite. It reflects the placental and maternal status, while the arterial blood sample, it tells you about what was going away from the baby and reflects the fetal status. Step 2, in the analyzing the code pH, we have to look at the pH. Is it low or normal? So if it is more than 7.2, it's normal. Less than 7.2, it is low. So it is acidosis. Then the next step is to look at the base deficit, which reflects how the bicarbonate is being used to buffer acids. So look at the base deficit. If the base deficit is normal, it is less than 12. So look at the BCO2. If BCO2 is greater than 60, so it is respiratory acidosis. Usually the outcome will be good, and just with the resuscitation, positive pressure ventilation, the baby will be fine. And I wish I read about this before. It is good, like, you know, that when you read the, you know, the printout of the code pH, I don't use to look at all these parameters. Now I will look at them. At least if you see that the code, okay, if there is fetal or there is neonatal acidosis, but the base deficit is less than 12 and the bicarbonate is high, you know this baby will have a good outcome with good resuscitation. And here you can blame the pediatrician if they didn't resuscitate well. Step 3, if the base deficit is greater than 12, again, we are still in the step 3. So if it is greater than 12 and BCO2 less than 60, so this is metabolic acidosis. And if the base deficit is greater than 12 and BCO2 is greater than 60, it is a mixed acidosis. Both usually they have the same outcome. These are the normal values for the cord blood. So arterial should be from 7.2 to 7.3. The venous 7.3 to 7.4, and partial pressure of carbon dioxide, it is from 45 to 55, and in the vein 35 to 45. Of course, we have to take sample from the artery, very important to take from the artery, not from the vein. And BO2 should be 15 to 25, and base deficit less than 12, that is in a normal one. So how does fetal acid-base status relate to the electronic fetal monitoring? Of course, it will be explained by those who will talk about the CTG, but I'll just explain a few points. So the presence of fetal heart acceleration, it predicts the absence of fetal metabolic acidemia at the time it is observed. So any acceleration, it means this fetus is not acidotic. Normal variability also predicts absence of metabolic acidosis at the time it is observed. And you know, actually, if we go through fetal physiology and how we read the CTG, this is all goes with, even before we start to know about fetal physiology and CTG. When I started my OB-GYN career in 2004, you know, all the seniors, they used to say, oh, this baby will do well because variability is fine. So I think we have already, you know, we have already observed, though we don't publish, we don't tell others, but we have already observed that, because many times, I remember very well, many times when we go for a cesarean for deceleration, the senior will say, this baby will have a good outcome because still maintaining variability. So presence of acceleration and variability, especially the variability, if there's no acceleration and there's variability, it indicates a normal outcome, and this baby unlikely to be acidotic. Scalp stimulation and vibroacoustic stimulation. This is indirect method of
5
yes.
more minutes.
Okay, I'm finishing. So it is indirect method of acid-base assessment during labor. So if you do scalp stimulation, and again, this is also, we do it since I started 20 years ago. When we do the VE and we see acceleration, we get reassured. So, but absence of acceleration, it doesn't predict fetal outcome. شكل البرزنتيشن القديم اللي فتحته. Anyway. So when baseline is stable and there is moderate variability, this is confirmed absence of, this is not mine. أنا كاتبة thank you. كنت كاتبة لكم thank you. شكلي فتحت بعد ما سكرت فتحت واحد ثاني. It's okay. So we are, I'm done. You will ask me questions or will continue or what? Thank you.
Thank you, Dr. Badria. Very informative lecture. Dr. Moza would leave the questions to the end.
Yeah, I think there is no question in the chat or QA.
Oh, okay, it's just about the
so we will continue with the second speakers. But Badria, will you be with us till the end, or you are leaving?
I can open with my phone. I will open with my phone just to answer the questions. But I want just to give the final message when we read, because I'm really happy about learning this part, how we read the cord blood and how we can see, like, is it metabolic acidosis or what outcome? You know, we see all of us obstetrician, and when you have asphyxiated baby in the SCABU, you get worried. And every day you will check either by phone with the SCABU or opening the electronic system, see your baby is better or not. Sometimes even reading the code BH and knowing what does it present, you might feel comfortable and you know the outcome.
Thank you, Dr. Badria. Thank you. I think it was very informative, especially regarding reading the code BH, because even us seniors, sometimes we overlook these things, which sometimes can be reassuring for understanding the outcome of the baby. Thank you, Badria. So we'll go ahead with the second speaker, Ahlam.
Yes, I would like to welcome Dr. Tamima Al-Zaghaifi. Dr. Tamima is a senior consultant in maternal fetal medicine at Sultan Qaboos University Hospital. She is also the program director of the obstetric and gynecology residency program. She will be talking today about the limitation of CTG and how rationale it is to use international guidelines in clinical practice. Dr. Tamima, over to you.
Thank you, Dr. Ahlam, for the nice introduction. I would like at the beginning to obviously thank Dr. Moza and her group for organizing this day today, which is a very, very important topic for all the hospitals, obviously, and the whole country. So I'll start. My topic is mainly regarding guidelines for the CTG monitoring or fetal monitoring during labor. So why do we do fetal heart monitoring during labor? It's mainly to avoid the fetal injury by identifying signs of hypoxia before it's sufficient to lead to a long-term neurological damage. So Dr. Badria already gave us a very nice introduction about the fetal physiology, and we all know how does it happen. Now, our aim is to be able to identify the baby who is at risk or the fetus who is at risk, so we can deliver that fetus before there is, I would say, a long-term fetal injury or neurological damage. There was a meta-analysis published regarding the use of fetal monitoring during labor, comparing all the RCTs, and they compared electronic fetal monitoring, which is the continuous and the intermittent auscultation. And they have found that neither of them are particularly reliable alone on determining the fetal reserve. So the whole clinical picture, as Dr. Badria have already stressed in her lecture, it's very important. It's not only the CTG, it's not only the findings. We have to always visit the whole clinical picture. Who is the mother? What is this fetus? If he's IUGR, normally grown, the reserve of that fetus. And obviously human factors, because we are at the end humans and mistakes can happen. And obviously there is a lot of variability on interpretation of the CTG. So regarding the CTG itself, it has been very well proven that it's a sensitive indicator where there is a low specificity and low positive predictive value. So what does that mean? That if we have a normal CTG, and we all agree that this is a normal CTG trace, the risk of that fetus has hypoxemia or acidemia is very, very low, okay? But with the presence of suspicious and pathological tracing, we have limited ability to predict the metabolic acidosis and low Apgar scores. So in a way, I find this is kind of reassuring to me, because as long as you have a normal CTG, then you are reassured about the status of that fetus. The only ambiguity comes with the, obviously, the findings on CTG and how to read them. And there is also well documented that there is a big intra and inter-observer disagreement on identifying and classifying the decelerations, evaluating variability, classifying traces as suspicious or pathological. All aspects of the CTG interpretation are actually most susceptible to disagreement between clinicians. So not only the clinicians, only the same person, if you gave him the same CTG trace and you tell him about maybe the outcome, they will have a different view than if they don't know the outcome. So that's why the CTG needs a lot of training and attention from our side. So it's very important, as I said before, that the maternal and fetal condition should be assessed, because they are very important to define the likelihood of the fetus developing hypoxia in labor. So it's very essential to review maternal history, perform full physical examination at the start of labor, and obviously risk assessment and recommend method of the fetal monitoring at the start of labor depends on the on your assessment. So as we said before, with the basic fetal physiology, a fetus in utero is designed to cope with labor. The thing is that we have to understand that some babies may not cope as well in labor, especially the babies who are already compromised, like IUGR babies, like babies with diabetic mother, hypertension, abruptio placenta. If there is already an unhealthy placenta, they will have a lower coping mechanism. This will also help in deciding the escalation and action when there are concerns with the fetal heart, either as seen on the CTG or heard during the intermittent auscultation. So it's very, very important, and we have to stress it again and again, that we have to consider the whole clinical picture and not only the CTG picture. Dr. Badria already said regarding the gas exchange at the placenta, as long as the baby has sufficient time between contractions, and that this is a healthy placenta, and the umbilical cord is not occluded, and the mother is not hypotensive, they should be able, you know, even if there was some hypoxemia, it should be able to resolve with the placental perfusion restored in between the contractions. So what are the factors influencing the fetal oxygenation? We already know that maternal factors like pyrexia or chorioamnionitis, hypotension, dehydration, anemia, hypertension, some types of analgesia or anesthesia. Also, the uterus or the placenta, uterine hypercontractility is one of the main factors that might lead to fetal hypoxia. So always remember about how much is this mother contracting, and maybe, as you know, most of us, the first thing to do is actually to switch off that oxytocin drip if it is there, or maybe even reduce it, or if she is not on any oxytocin, we sometimes even give uterotonics. We have to think about impaired placental function, abruptio, cord prolapse. Obviously, the fetal condition is very important, like growth restriction, fetal bleeding, infection, and anemia. Now, regarding the response of the fetal heart rate to reduce oxygen level, I'll go through this quickly because I believe with our colleagues later on, they will speak about it more in details. So hypoxia may develop over hours, obviously, during labor. And the fetus respond with compensatory mechanisms to avoid hypoxic injury. So what do you see in the CTG? You might see increase in the heart rate because the cardiac output increase, and it will lead to release of catecholamines and stress response to supply the vital organs. Then there might be a loss of baseline variability if the hypoxia persists, because the fetus will start to reduce the amount of the oxygen used in order to perfuse the vital organs. Acceleration will disappear, and deceleration might happen, and even slowly might become more and more frequent. And sometimes if that fetus is in too much of a stress, then it will present even with acute bradycardia, where the fetal pH can drop by 0.01 every minute. So this is a very important, crucial time in the management. So going through the international guidelines, I went through mainly all the guidelines, ACOG, the SOGC guidelines, which are a little bit different. I would say they categorize it to category 1, 2, 3. So I'm concentrating here about the FIGO and NICE guidelines, which are similar. FIGO was introduced, or it was released in 2015. And we have the NICE intrapartum care guidelines in 2007. That is an update from 2014 after a lot of, I would say, concerns from stockholders. So they had to revise their 2014 guidelines, and they produced another guideline 2017, which is, I would say, it's more similar to the FIGO guidelines, a little bit more complicated, but it's very much similar. We have also the NICE intrapartum care guidelines for women with medical conditions, and that will include even intrapartum care management, including recommendation method of intrapartum fetal monitoring in high-risk women, specifically heart disease, asthma, acute kidney injury. So it's very, very good also to look through them. It's very crucial as a country or as an institution to have your own guidelines that you are working with in the hospital. Ideally, we should have Oman guidelines, and that's what I will suggest, obviously, to the Ministry of Health. We should have the guidelines for electronic fetal monitoring during labor in Oman. However, I'm sure that both of us in the hospitals, we have our own local guidelines. It's very important that documentation is there. It's essential for all staff to use the agreed system. As I said, we have to do more CTG interpretation rather than pattern recognition. Human factors, good communication is vital for staff, for women and their birth partners. Also documentation, very, very important. It has to be standardized, system of assessment, classification, included the clinical context and escalation of the action plan. So I'll start by, this is basically from NICE guideline. It doesn't mean that we'll have to do it in Oman. Now, what they do in UK, because they have a lot of birthing centers, which is midwife-led, not all the patients will deliver in hospitals. So they are going with the intermittent auscultation that can be offered for all women, healthy women, without any risk factors. The risk factors that we are already spoke about, whether it's maternal, fetal, placental, obviously all of these women should go for electronic continuous fetal monitoring. Continuous risk assessment is necessary if you choose the intermittent auscultation, because if there is any changes in the mother condition or in the fetal condition, obviously, then a switch has to be done to the electronic fetal monitoring. So how do we do intermittent auscultation during labor? As I said, the assessment at the beginning is very, very crucial. So you should not start a woman at risk at the beginning with intermittent auscultation. If it is a very, very healthy pregnant woman, which is unlikely that we see here in Oman, I don't know why we are all, most of our patients they have some kind of risk factors. Then if you choose intermittent auscultation, then you go for, listen for at least 1 full minute. The time, when do you listen to it? It has to start listening toward the end of the contraction or as soon as it's comfortable for the mother. That's what the FIGO says. A NICE will say immediately after the contraction. And the interval is very crucial. So in the first stage, you have to listen at least every 15 minutes. In the second stage, every 5 minutes. And that's from the start of the second stage of labor, not from the start of the pushing time. So that's from the start of her being fully dilated. We have to remember that. Clearly documented, recording on bartogram is very crucial. There was this report of Embrace report of the UK 2017 intrapartum related perinatal confidential inquiry. So they review all, I would say, or most of the perinatal mortalities. And what they have found that the main issues where there was any intrapartum fetal death with intermittent auscultation is that there was a failure to recognize the start of the established labor. So the intermittent monitoring was not done in time. The frequency of performing the auscultation is inconsistent with the national guidelines, and there is inadequate documentation on the bartogram. So we have to remember those issues in order to avoid them. Now, going more toward the electronic fetal monitoring that we are doing here, I believe, all over Oman, as far as I understand. It requires a combination of continuous risk assessment and consideration of the whole clinical picture. As we said before, obviously recognition of the fetal heart changes and the concerns. Documentation, I cannot stress it enough, it has to be standardized, summarized, and communicated effectively. Actions plan and communication is very important to ensure that there is escalation of a possible problem. And obviously additional methods to assess fetal well-being is, if required, if there is fetal scalp stimulation, as Badriya said, we use it since ever, fetal blood sampling in some units, and sometimes we need ultrasound. Now, I'm showing you this. I know you know, every one of you know what a normal intrapartum CTG looks like. The standard paper speed is 1 centimeter per minute for all the guidelines. And you know all the 5 features of a normal CTG. So when the CTG is classified as normal, it's likely that the fetus is coping well with labor. So we don't expect hypoxia in that fetus. However, when it starts to deviate from normal, then that's when maybe issues can arise. So we already know what is the normal. Okay, I wouldn't go through in details of that. You all know, all of you know that. Now, if pathological, and this is the FIGO 2015 guidelines, because they are, I would say, more simple than the NICE, which is a little bit more complicated, but it's similar. If it is pathological, also it's usually, I would say, easier to recognize, as we all agree. So if the baseline is less than 100 beats per minute for more than 10 minutes, reduced variability less than 5 beats per minute for more than 50 minutes, increased variability is also bad if it is more than 25 beats per minute for more than 50 minutes, and sinusoidal pattern for more than 30 minutes. If there is a repetitive, late, prolonged, more than 3 minutes deceleration for more than 30 minutes, or more than 20 minutes if reduced variability, or if there is isolated deceleration, which continues for more than 5 minutes. With the pathological, there is always a high probability of hypoxia and acidosis for this fetus. Then there will be immediate action to correct reversible causes, adjustment methods, obviously, as what I'll speak about some of them a little bit, I mean, I would say in in short. If this is not possible, then we have to deliver that fetus. In acute situation, immediate delivery should be accomplished, obviously, especially with the bradycardia. Now, the main problem is when there is the suspicious CTG, where it's classified as suspicious because it's lacking at least one characteristics of normality, but with no pathological features. So there is a low probability of hypoxia and acidosis, as we said before, with abnormalities in the CTG. Most of the fetuses are still not hypoxic, but there is no way for us to know. I mean, there are some methods, but still, we cannot always pinpoint which fetus is hypoxic at this stage or no. Already, obviously, it will depend on a lot of other factors, maternal, fetal, placental factor, as we said before. So the whole clinical picture is very, very important to consider. Now, I like this slide. I got it from the Irish guidelines. They have incorporated the Dr. C. Bravado with the FIGO, normal suspicious pathological classification. And they use this for a documentation of all fetuses during labor, I mean, during their labor monitoring. So it's very, very nice way of actually, when we monitor fetus, we have obviously to keep on monitoring minimum every 1 hour in the first stage, and minimum of 30 minutes in the second stage. That's if it is normal CTG. But if it is, obviously, there is any suspicious features, then you have to do the evaluation of the CTG more frequently. So we all also know the Dr. C. Bravado mnemonics, which is determine the risk, contractions, baseline, fetal heart, variability, acceleration, decelerations, and the overall impression has to be documented. What do you think? And then the management plan. And then you have to sign here and print your name, obviously designation. And so that's a very nice way of actually completely document what had happened with that encounter. Now, going through some of the suspicious, I would say, features, there's something called variable deceleration, which are V-shaped deceleration, a quick drop and a quick back up. So this is usually benign. We don't expect a lot of, we don't expect hypoxia on those babies if it remained V-shaped like that during the labor. But as we know that most of the variable decelerations are not V-shaped. I would say most what we see is like what looks like this in this slide, where whether they are like wide, they are U-shaped, they are coupling of contraction before of deceleration before going to the baseline. So these are concerning features, and we have to consider them as suspicious because there might be some hypoxia in that fetus, especially if they happen in more than 50% of the contraction. Late deceleration, again, we all know what late deceleration looks like, and a mirror image basically of the contraction. And again, repetitive deceleration are described if they are more than, if it happens in more than 50% of the contractions. And this is a concerning feature. Now, if it is CTG, if it is suspicious, and I would recommend you to read the guidelines because I don't want to go into details of all of this because it will require really a CTG interpretation course to do that. I don't think I have the time to do that, but there are some pathways and guidelines to tell you what you should consider, what action plan and escalation you have to do for each of those, I would say, categories, and also for the pathological CTG. Now, Dr. Badria also spoke about fetal scalp simulation. Again, it's mentioned in FIGO and NICE guidelines, and that actually, if there is an acceleration of fetal scalp simulation, that gives us a reassurance that this fetus is not hypoxic at that time. We have also the fetal blood sampling in some units. It is sometimes used as adjuvant to the CTG findings, and it's recommended by NICE and FIGO if you have it in your unit. There had been uncertainty though, if it improves neonatal outcome and reduces intervention rates as we originally intended. So some studies had showed that it reduced the cesarean section rate. Other newer studies, like this study, showed that there is no evidence that intrapartum cesarean section delivery is reduced by using the fetal blood sampling. So now most of the guidelines are saying also that the availability of fetal blood sampling in all units should not be considered as a requirement for safe provision of the intrapartum care. Regarding also the fetal pulse oximetry and the fetal ECG segment analysis, the STAN, also it has shown that there is no evidence of their role in reducing perinatal morbidity or operative delivery, so they are not standard of care. There is this infant trial, which was also done to determine if a computerized decision support system of the CTG itself, like what we have with the EEG, there is a computerized, I would say, assessment of the trace. If that will help in reducing the adverse outcomes or the operative delivery, and cost effectiveness, obviously, and the result was released in March 2017 and suggested that there were no significant clinical outcome advantages or reduced intervention rate by using the computerized decision system support. So we will stay with what we are having. We have to basically keep on improving our staff, ourselves, understanding of the fetal physiology, CTG interpretation, and trying to avoid, I would say, adverse outcomes or neonatal injuries by more training and more effective utilization of the system that we are working with. I'll be also quoting this, the Embrace UK report on the perinatal confidential inquiry of 2017, where they say that the continuous electronic fetal monitoring was not commenced when there was concerns with intermittent auscultation in a quarter of cases. So that's what I'm saying, that sometimes things are not done as per guidelines, and that's why incidents happen. Also, an hourly review was not undertaken in half of the cases with electronic fetal monitoring. So they will put them in the machine, and then nobody will go and look at that trace every hour and make sure that it's fine. Obviously, now most of the units will have this big screen where the nurses, I hope that that will happen in all the hospital, at the nursing station with one nurse or the head nurse usually looking at all the traces in all the rooms and identifying any issues or abnormalities in the trace. Or obviously, if it is electronic and, high-tech electronic, then it will give you also a heads up that there is a problem with that, or alarm, for example, that there is a problem with that room. There is always a delay in the referral to medical staff. Sometimes nurses or midwives, they will note something, but they don't recognize the abnormality, and then they don't alert or they don't escalate. There was evidence of lack of situational awareness in many of cases also, that they think that it's normal. So always a fresh eye is also very important if you are in doubt. So at the end, I'll give you just a few points to remember. Make a documented systematic assessment of the condition of the woman and her fetus every hour or more frequently if there are concerns. Do not make any decision about a woman's care in labor on the basis of CTG findings alone. So we have to always take the whole clinical picture. Take into account the woman's preferences, any antenatal and prepartum risk factors, the current well-being of the woman and her fetus, and the progress of labor. Ensure that the focus of the care remains the woman rather than the CTG. So don't get trapped in the CTG and go out and in of the room looking at the CTG without speaking to the mother. So talk to her and her companions because they will get worried. When reviewing the CTG trace, assess and document contraction and all features of the fetal heart rate and document them. Documentation is very important. Assessing without documentation, it will not help you later on if there is any bad outcome. It is difficult to categorize or interpret the CTG trace. Obtain a review with a senior midwife or a senior obstetrician. Always try to get a fresh eye to look at that CTG. If you are tired or if you have been working for long hours, sometimes a human being will be trapped in certain circumstances. So always try to get a fresh eye, either a colleague or a senior or a doctor or somebody to help you in reviewing that CTG trace. Now, the way forward for Oman, I always like guidelines. So I think we should come up with Oman National Intrapartum Fetal Monitoring Guidelines, where it will be the base for our practice all over the country in all the different hospitals. We have to have and initiate and maintain, if some of the hospitals already have, a regular maternity staff training and certification for CTG interpretation. It's very important. We have to bring it back. Staff should at least get those certification or a CTG monitoring course maybe every 2 years, if it is not yearly. We have to start a national review, national registry first of perinatal mortality cases, and the review of the intrapartum stillbirth and early neonatal death, and obviously the sentinel events, so we can improve. Without us knowing where are we cannot improve our healthcare provision for our patients. With that, I will end my presentation. Thank you so much for listening. This is the information sources that you come to. You can actually go back to it. And thank you so much for listening.
Thank you, Dr. Tamima. Thank you for the excellent talk. And I like your last slide about our national requirement for improving what we have currently practiced. There are a few questions for you, Tamima, and I will start with the last question regarding from Dr. Sonam, for how long we should continue with early deceleration to consider them as normal physiological variants in CTG. So if you have a CTG with a persistent recurrent early deceleration, for how long you will say, okay, I will still wait and I will not rush to deliver this patient?
So again, going back, Moza, it's actually an excellent question. We go back to the basics, right? We always think about that patient as a patient. It's not about only CTG finding, isn't it? It's about the whole clinical picture. So who is this patient? What are her risk factors? How is the fetus? Well-grown or IUGR? What is his risk factors? And the risk factors in that fetus. Then where is she in labor? Is she actually in the second stage that it is normal for her to get, a repetitive type 1 or early deceleration? Or this is something unusual if she's still 4 centimeter dilated. So the whole clinical picture, you cannot really say after this and this time. I wish it was that easy, okay, then we will be, I would say we'll be in safe hands, or we will be easier to go ahead with our decision. It really depends from a case to a case. If the patient is in labor and she's already in the second stage, and those early decelerations are every now and then, or if she's pushing, she's already expected to deliver soon, it's very normal for her to have an early deceleration. But are those early decelerations are also early deceleration? You have to make sure, because they could be also with a latish component. Variability is very important. Obviously, the complete picture of the CTG in terms of the baseline fetal heart. So I wouldn't be able to give you a time. It really depends from a case to a case.
I agree with you, Dr. Tamima. I think, yes, I agree. We should look to the whole clinical picture and to the whole clinical scenario. We should move from the pattern recognition to understanding the physiology of the fetus in labor. And it's not only just the last, I would say the last only labor of the CTG. You should also compare it with the admission CTG. How was that fetus? And that's what we get actually. We get this conclusion of what is called the late or the normal finding of the second stage CTG. And if you go to that second stage CTG, it's not a second stage CTG, it was pathological, it was not because of the head compression, it was something else. So it's important to move from the pattern recognition to look into the whole clinical picture of the fetus and then accordingly decide whether this CTG need to have an action, or yes, I can wait because this is something physiological and something we can wait on it. There is another question. I think that is for Dr. Bedriya, but you can answer it, Tamima, because she's not around now. Do you do birth cord BH? I think do you do both? I think they meant arterial and venous. Is it recommended to do both arterial and venous, or just do venous and that's it?
Ideally, it should be arterial, okay? And it's not routine also on all babies. I mean, only if you are expecting bad outcomes. If you are at a unit where it depends really on your unit guidelines. So ideally, it should be venous. But if you are also very extra cautious, you can do both. And now coming back, Moza, I would like to also stress something that you have pointed before, is the admission CTG. Admission CTG is very, very important to document because it gives you an idea on what is the baseline of this fetus. Because if the admission CTG is already abnormal and it was not recognized, that's when problems will happen, because then the baby will end up with adverse outcome, and it will be as if this fetus had the intrapartum, all the sequelae happen only intrapartum, while maybe this actually happened before even presenting to the delivery ward. So admission CTG is very important.
Thank you, Tamima. There's one more question. Can you please repeat the meaning of mixed acidosis? I think that it was nicely mentioned by Dr. Bedriya about the mixed acidosis, which mean both respiratory and metabolic acidosis. When you interpret the cord BH, and you will see that the interpretation looks more not only respiratory, but it's also respiratory and metabolic acidosis.
I think what we can do, Moza, I would suggest to optimize the, I would say the benefit of this day is to send maybe all our slides to all the people who are involved, so they can review the slides.
Yeah, we are doing
want to review anything. Yeah.
Yes, we are recording the session, and I think we will send it.
Okay, excellent.
All. Yes. Thank you, Tamima. Thank you. I think we will move to the second speaker. And then at 6 o'clock, we will break for a brain, and then we'll come back.
Okay, so I would like to, yes, I would like to introduce the first speaker, Dr. Chitra. Dr. Chitra was a senior consultant obstetric and gynecology at the Royal Hospital. And she was the head of maternal medicine and high-risk pregnancy unit. She will be talking today about understanding fetal heart rate control and pathophysiology of fetal hypoxia in labor with the aid of CTG. Dr. Chitra, over to you.
Thank you so much. It's really wonderful to be sitting here. Good evening to all of you. I'm sitting in a small hill station in India, actually. And isn't it amazing that I'm sitting here and I'm able to talk to all of you? So I'm going to talk today about understanding fetal heart rate control and pathophysiology of intrapartum hypoxia. The absolute basics, however, something that is extremely important. During labor, a fetus undergoes the most stressful journey of its life and uses all its resources to adapt to the constantly evolving and changing intrauterine environment. We know that. And the clinical goal of electronic fetal monitoring is actually to identify those fetuses who are at increased risk of hypoxic injury so that appropriate intervention can be taken to avoid an adverse outcome without actually causing unnecessary intervention as well. So we've already learned that labor involves hypoxic and mechanical stresses as a result of progressive increasing uterine contractions as labor progresses. And, it can cause compression of the umbilical cord. There could be occlusion of the spiral arteries, and this leads to interruptions in the uteroplacental circulation. So Badria told us about the compensatory mechanisms that each fetus has to withstand these hypoxic and mechanical stresses to adequately supply oxygen to all the vital organs. So it's important to understand the pathophysiology so we can understand which fetus is compensating and when decompensation actually occurs. So occasionally these mechanisms which have been provided by nature are overwhelmed and then neurological injury occurs. So each fetus has its own physiological reserve based on a combination of antenatal and intrapartum factors. Hence, individualization of care is essential to optimize outcomes. No CTG is complete without careful assessment of the clinical situations. Some fetus may already have chronic uteroplacental insufficiency. Note the presence of chorioamnionitis, fetal anemia, acute hypovolemia, which occurs in abruptio placenta. Uterotonic agents sometimes, which we use, we forget, oxytocin, they also increase the risk of hypoxic ischemic injury. So this is what Dr. Badri had already told us, that this is nature's way of helping the fetus. The fetus myocardium beats at a higher rate, 110 to 160 beats per minute. Unlike adults, the fetus hemoglobin is 18 to 22 grams. The hemoglobin F has a much higher oxygen carrying capacity than the adult hemoglobin. So what happens when the fetus faces a stress, a hypoxia? So in response to stress, the fetus tries to safeguard the myocardium, which is the pump, because this is the pump which is going to perfuse all the vital organs and avoid hypoxia. So in adults, when there is a stress, they increase the respiratory rate. However, fetuses cannot do that. So they rapidly increase the oxygen levels by decreasing the myocardial workload by reflex slowing of the fetal heart rate. And this is a deceleration, and we're going to come to that in a little bit more. Now, if the stress continues, then the next response is a loss of accelerations. And how does that happen? The fetus tries to conserve energy by stopping all its movements, and then you have loss of accelerations. If still hypoxia continues, the fetal adrenals release catecholamines. So what do catecholamines do? They increase the placental circulation, they cause peripheral vasoconstriction and send all the blood to the vital organs. Catecholamines increase breakdown of glycogen, and they convert it to oxygen, which is an increase to increase the energy requirement. So this is, in short, how it happens. Loss of first there is decelerations, loss of accelerations, release of catecholamines. Catecholamines are causing peripheral vasoconstriction. They are increasing the heart rate and glycogenolysis. So failure of any of these mechanisms may lead to the onset of hypoxia and acidosis, and then it leads to neurological damage, decompensation occurs, and there could be death later on. So fetal heart rate is controlled by both autonomic and somatic nervous systems. The autonomic nervous system is the sympathetic and parasympathetic, and there's a constant interaction between these two systems. And this is what we know as variability. While the somatic system is responsible for voluntary control of body movements via skeletal muscle, and this accounts for the occurrence of acceleration on the CTG. Now, the parasympathetic system, it attempts to reduce the heart rate in response to any hypoxic stress, which is decelerations. And this activity is mediated by two kinds of receptors, which are the baroreceptors and the chemoreceptors. Now, the baroreceptors, these are stretch receptors, and they are situated peripherally, and they are stimulated by stretch, by increases in pressure. And during labor, when there is a head compression, this leads to an increase in the blood pressure, and it stimulates these receptors. And then these receptors via the parasympathetic system cause a slowing of the heart rate. These baroreceptor mediated decelerations are called as early decelerations or variable decelerations. We know they are short lasting, and the fetal heart rate returns to the baseline. They normally do not cause any hypoxic injury. Now, it's the chemoreceptors which are stimulated by the chemical situation, by the biochemical composition of the brain, and they are activated when there is a acidosis. So these chemoreceptors are stimulated, and then they cause a reflex decrease in the fetal heart rate. These are what we know as late decelerations. These decelerations we know take longer to recover because fresh oxygenated blood needs to reach the maternal sinuses to remove these chemicals from the blood. And these are the ones which are associated with acidosis. And if these decelerations continue, which are resulting from hypoxic stress, they will progressively become deeper and wider with the continuation of labor. So it's important to recognize these decelerations. So let's look at the features of a normal CTG. We all know it, but let's look at it from the pathophysiological angle. So this is a normal CTG. It's got a stable baseline, good variability, which means the autonomic nervous system is intact. Presence of accelerations tells us that the somatic nervous system is intact. No decelerations, presence of cycling, no hypoxia. And these patterns become clearer after 32 to 34 weeks of gestation with the maturation of the nervous system. The baseline heart rate, we know about it, but what is important to remember that this, if the baseline heart rate is more than 160 per minute, it is known as baseline tachycardia. And this could be physiological for a preterm fetus due to the immaturity of the parasympathetic system. While a baseline of less than 110 could be physiological for a post-term fetus. So if you find a higher heart rate in a post-term fetus, then that itself should be a reason for concern. A rise in heart rate may be a fetus who's attempting to respond to hypoxia. So the baseline of each fetus should be used as his or her control. As well as an absolute value, it is important to consider the trend over time. For example, if a fetus has a baseline of 150 per minute, that may be quite normal according to the guidelines. However, if it started with a baseline of 110 and it has gone up to 150, then that's something to worry about. So in ongoing chorioamnionitis, remember that the baseline may even go up without preceding, without any decelerations preceding it. So in almost as far back as 1965, they had done a study and which showed that fetuses with tachycardia plus decelerations were much more likely to result in depressed infants, especially if this occurred more than 2 hours prior to delivery. So the significance of fetal tachycardia as an indicator of the fetal condition is often missed when evaluating the progression of fetal heart rate changes. Recent research has strongly suggested that combination of decelerations with tachycardia is one of the strongest predictor of metabolic acidosis. So look at the CTG carefully for slowly increasing fetal heart rate over a period of time to recognize that catecholamine mean response to fetal hypoxia. Look at the CTG at the beginning of labor, or even antenatally, or in the ward if a CTG has been done, to know what the baseline CTG for this particular fetus is. Variability, a normal variability implies that the autonomic nervous system is functioning well. And as we have already said, it's a continuous interaction between the sympathetic and parasympathetic nervous system. Increased variability. This may actually occur in rapidly evolving hypoxia, especially in the second stage of labor with active pushing. We've often seen this saltatory pattern in the second stage of labor. Urgent action needs to be taken to improve oxygenation, stop oxytocin if that's what is happening, tell the mother to stop pushing, especially if the saltatory pattern is there. And if it doesn't respond, then the mother may need urgent delivery. Accelerations are the hallmark of fetal health, especially if it's along with cycling. Remember, accelerations are never associated with contractions or with stress. And they, of course, reflect the integrity of the somatic nervous system. Decelerations, we know, they've traditionally been classified as early, late, and variable. However, during labor, more than one pathophysiological process may occur simultaneously. And actually, true early decelerations are uncommon. And early decelerations in early labor should be viewed with caution. I think somebody's already asked this question about early deceleration because head compression is unlikely. And these actually may be variable or late, and we are misclassifying them. Late decelerations, we know they are late because as the contraction ceases, these are stimulated by the chemoreceptors. The placental venous sinuses, they have to refill with fresh oxygenated blood. And therefore, there's a delayed in recovery of the fetal heart rate to the original baseline. Actually, approximately 80 to 90% of all decelerations are variable. And if they are typical or uncomplicated, then they are due to mechanical compression of the umbilical cord. And they may actually continue for a long time before hypoxia develops. However, they may become frequent over time, wider, deeper, and lead to all these atypical pattern, which we have already, I think Dr. Tamima has mentioned it. Atypical decelerations may be due to sustained cord compression and coexistent uteroplacental insufficiency. If they are associated with other CTG changes, it may indicate that the fetus is losing its ability to compensate for the ongoing stress. Therefore, again, it is essential to reevaluate the CTG over time. In fact, there was a recent poll, this was done in UK, and they found that most of the caregivers, they evaluate only the last 15 to 30 minutes and rarely go back to the fetal heart rate tracing in its entirety. So these are actually pictures of some variable decelerations. So an acceleration which follows, I mean, this high, it's not really an acceleration after a deceleration. It is an overshoot, and it actually may be a compensatory response of the fetus who's trying to compensate for the hypotension. And these pictures are actually taken from Professor Arul Kumaran's book on fetal monitoring in labor, and he's labeled it as the dying fetus. This is how the decelerations would progress if action isn't taken, if the fetus is facing a hypoxic stress. So you'll see there's here, shouldering has disappeared, there's no variability here, and they have become biphasic. Ultimately, there's absolutely no variability here. Tachycardia, shorter interval between decelerations. The decelerations are becoming deeper, and ultimately terminal bradycardia. So if there's one message that we are going to take from this entire webinar, it is this: the importance of reviewing the entire CTG trace and considering the clinical scenario rather than just a segment of CTG trace in isolation. It cannot be overemphasized. So now I'm going to talk about the different types of intrapartum hypoxia. It's important to know how the CTG appears in these types of hypoxia so that timely action can be taken. It's been classified based on the rapidity of evolution of the hypoxia. Acute is sudden cessation of fetal circulation. Subacute developing over 30 to 60 minutes and gradually evolving may develop over several hours. And chronic hypoxia is which may occur in patients who already have an insult even before they enter labor. So I'll talk about these three, and Dr. Jayashree will be talking about the fourth one. We know about acute hypoxia very well. A single prolonged deceleration with a sudden drop in fetal heart rate to less than 80 beats per minute, which lasts for 3 minutes. And I think we are very good at taking actions against this. And this here, the fetus rapidly drops the heart rate to protect the myocardium from hypoxic injury. And the intrapartum, there are only 3 intrapartum accidents which can cause this: cord prolapse, placental abruption, and uterine rupture. And iatrogenic causes could be maternal hypotension, uterine hypostimulation. The fetal pH drops at a rate of 0.01 per minute during this prolonged deceleration. We know the management. We know the 3, 6, 9, 12 minute rule. Now here we are talking about a CTG which was perfectly normal, and then there has been a sudden drop in the CTG. And if the fetus has already been exposed to gradually evolving hypoxia and labor, its reserve will already be compromised, and that's a different story. Here, the baby will have a decrease of pH of 0.15 at the end of 15 minutes, and you still would have a good outcome. So what the literature says that in the absence of these above major accidents, if the CTG has been perfectly normal and then you get this, over 90% would recover if in the absence of the above major accidents in 6 minutes' time. Subacute hypoxia, it presents on the CTG by the fetus spending more time decelerating to protect its heart, with only 1/3 of the time at the baseline to exchange gases. So the fetus is spending more time here and hardly any time, so it doesn't get enough time to oxygenate the blood, and therefore it can develop acidosis. This is almost invariably caused by uterine hyperstimulation, and in the second stage of labor. The fetal pH drops at the rate of 0.01 every 2 to 3 minutes, as compared to every 1 minute in acute hypoxia. So take action, stop oxytocin, ask the mother to stop pushing to allow recovery of the fetus. In case there is no improvement within 10 minutes, then delivery should be expedited. Now, this is the most common and the most important type of hypoxia, I should say, gradually evolving hypoxia. And this is where most of the misinterpretation and the errors occur. Here, the fetus is undergoing some changes and is exposed to hypoxia over time. So it has time to mobilize its resources to compensate. However, if no action is taken, then acidosis will develop. So a compromised fetus will exhibit a predictive progression in the fetal heart rate pattern. So if a fetus is exposed to a hypoxia, then it will gradually, these following patterns will occur. So first of all, decelerations occur. We've already discussed that. The next that happens is loss of accelerations and lack of cycling. If the hypoxic stress continues, then the decelerations become wider and deeper. And then you get the catecholamine surge, which produces tachycardia. First sign noted is a rise in baseline. And this is the one we must recognize. If this compensation fails, then the fetus starts to decompensate, and that there will be reduced variability, and finally terminal heart failure and the final bradycardia. So most fetuses are developing acidemia when their fetal heart rate tracing shows tachycardia with worsening baseline variability. This is when the fetus is progressing from adaptation to deterioration. And in the absence of a correctable etiology, this may be the most important time to time delivery and not to wait anymore. Reduced fetal reserve in the presence of certain conditions, not to forget, such as fetal growth restriction, preeclampsia, all the things that we have mentioned before. If the fetus has these, then it may deteriorate and become acidemic even much faster and may require more rapid and aggressive management. So I'm going to just show you this case which demonstrate all the things that we have just discussed. And this is one of the patients, it's an actual patient actually. This was a priming gravida whose post dates, and she was admitted in labor like it was clear. So note the baseline. The baseline is already 150, which is already a matter of concern. Anyway, labor progressed. And somewhere here, the labor was felt to be slow and she was augmented with syntocinon. Note the contraction. She's already getting some variable decelerations. This is what we said, which is the overshoot. It's not accelerations. And the variability is reducing. Now, when we audited this case later on, we asked, the caregivers had actually misinterpreted it and they thought this is the baseline and these are accelerations. But remember, this is the baseline actually. If you look at the first trace, you'll know this is the baseline. And the baby will not accelerate along with contractions. Look at this. And this continued because the CTG was misinterpreted. And finally, the baby, she delivered here. She was in second stage. She was pushing. The baby was born flat, intubated. And as we have expected, the outcome was not very good. So what are the lessons that we have learned from this? Recognition of the baseline heart rate for each fetus. Accelerations are not associated with stress. Take note of the contractions. Possibly if the mother had been asked to stop pushing, if the syntocinon had been stopped in time, there might have been a better outcome. Increasing hypoxia causes fetal tachycardia. Recognize the catecholamine surge. And again, I stress it is important to take note of the heart rate at the beginning of the trace and compare it with the current rate. So I'm reaching the end of my talk and I'll just highlight the key points. The first is the clinical picture, which we have already discussed. The cumulative uterine activity. Unfortunately, the CTG doesn't tell us the strength of the uterine contractions. Try to calculate, I believe, the total contractions over 10 minutes rather than just the frequency, the total time spent over contraction, rather than just the frequency of the contractions, especially when oxytocin is being used. This gives a better indication of the ongoing uterine activity. Cycling and acceleration signify healthy somatic nervous system. Careful assessment of the baseline variability, the central organ oxygenation, loss of variability, unstable baseline reflects hypoxia to the central organs. It is vital to recognize the catecholamine surge. It is vital to recognize this fetal attempt to compensate for ongoing hypoxia by a slow and progressive increase in the baseline over a period of time. Try to see the decelerations, whether it's chemo or baroreceptor, because they indicate mechanical or hypoxic stress, and to determine whether pathophysiology is either baro or chemoreceptor. Understand the wider clinical picture and the type of intrapartum hypoxia as we've discovered, whether acute, subacute, gradually evolving, and chronic, which we are going to come to right now. Consider the next change. Depending on the individual fetal reserve, remember the fetal compensatory mechanism and take timely action accordingly. I'll end my talk here. Thank you very much to all of you for listening. Thank you so much.
Thank you, Dr. Chitra, for this excellent talk. I really appreciate that you were able to join during your leave. I just repeat the same message that you have already said in your presentation regarding looking to the whole CTG trace and not only concentrating on the last 15 minutes CTG, because the whole CTG trace will give you a reflection how this fetus behaving in labor. Even the CTG which was in the ward, the CTG, the admission CTG, will give you how was the baby even before going into labor. So it's very important to look to the whole clinical CTG trace and not only concentrating on the last 15 minutes to understand how will this fetus cope with the intrapartum stress. There is one question which is very important, Dr. Ashitra. Everybody listening about the reduced variability, but this is the first time they are listening about increased variability and how this increased variability actually is not something called normal variant. Sometimes it may reflect abnormal response of the fetus. So can you again highlight this important point? Please?
Yeah, so the increased variability, invariably, you may see it in the second stage of labor. Actually, to be honest, even this is something I learned, and they call it the saltatory pattern. And if it continues over a period of time for 10 minutes, it may be the fetus was trying to compensate. So normally they said that if you ask the mother to stop pushing, in fact, when we see it, we tell her to push faster and harder. So tell her to stop pushing or stop the oxytocin, and it may improve. And then she can deliver. But if it continues in the second stage of labor, then probably you need to apply a vacuum or deliver her.
There's one more question also, Dr. Chitra, regarding fetal tachycardia. When you will consider this fetal tachycardia as normal, if variability is okay and there is no decelerations, for how
That's
long
right.
do you consider this?
Yeah, so if fetal tachycardia, if you can find a cause for it, whether it's due to certain drugs or it's happening, if the rest, it may happen in a preterm fetus, if the baby has no other risk factors and the variability is absolutely good, there are no decelerations, I think one can wait. But when it is associated with all the other ominous signs, then that is something really ominous. And I think, Moza, you'll agree with me that this is what has happened to a lot of our patients. People have missed that catecholamine surge and the increase in the rise in the heart rate.
Yeah, and there's one more point. I like it from the presentation, Dr. Chitra, regarding fetal resuscitation. I mean, when you see that there is fetal tachycardia and there's deceleration, you try to resuscitate this fetus either with IV fluids, giving oxygen, changing the position, or stopping syntocin. If this fetus is not responding to your action, then it means that this fetus needs to be delivered.
Yes. Dehydration. I mean, there are various causes. It could occur in dehydration. And if you, like Moza said, if you resuscitate, give adequate IV fluids, the hypovolemia is corrected, it may improve. If it doesn't, then obviously necessary action has to be taken.
I think we're done with the question. Let me see. I didn't understand this question. Yeah, do you have CTG guidelines in SQ or Royal? Yes, we have CTG guidelines. There's one more question.
Guidelines only.
I don't understand. Is last update code BH 7.1 is the normal?
That is for Badriya, no?
I think code BH 7.1, yes, we consider it normal, still taking into account the whole clinical picture. I mean, when you look to the code, or ABG or the blood gases, don't only concentrate on the code BH, look to the other parameters, and that's what has been highlighted by Dr. Badriya. You have to look to the BCO2, you have to look to the base deficits, you have to look whether it is metabolic, whether it is respiratory, whether it is mixed. So it's not only the core BH what we have to concentrate. I think that is the whole question that we have. I don't know. I think we should break for the brain time, and then we will come. We'll take 15 minutes break, and then we'll come back. Yeah. What do you think? Any more questions before breaking? Ahlam, I think you muted yourself.
Sorry, yes. There is one question. I think it's for Dr. Tamima. What is the amniotic fluid in Irish guidelines? Is it volume or color?
It's actually it's both. That's in the Dr. C. Bravado in the determined risk. Okay, so both of them are important. If antenatally the woman has reduced amniotic fluid, it is significant, obviously, that she's entering labor with oligohydramnios, and also the meconium. We know that it's very important to note meconium during labor. So both of these features are important.
That's actually a very important point also regarding the meconium. Is when there is meconium, forget whether it is thin meconium or thick meconium, it is meconium. So don't take even thin meconium as it is. Yeah, I can just wait with the suspicious CTG. there is meconium, regardless whether it's a thick or thin, and you have suspicious CTG, then please, this is very serious. You have to deliver this patient. If it is in second stage by vacuum, if it is still in early stage of labor and first stage, then you have to consider delivering this patient for cesarean section.
Yeah, I'll just add a little bit about meconium there. The thick meconium just means that the liquor is also reduced, because meconium is what is getting mixed up with the liquor and coming out. If there is liquor, then you'll probably get thin meconium. If there's no liquor, it'll be thick. So meconium is meconium anyway.
I think that's it. We'll go for a break and then we'll come after 15 minutes. Thank you all.
Thank you so much.
Shall we restart again, doctors?
Yes, please. Yes, okay, we can. أحلام. أحلام, I think we can start again.
Welcome back, everyone. It's my pleasure to introduce Dr. Jayashree for this talk. Dr. Jayashree Santosh is the consultant in high-risk pregnancy unit at the Royal Hospital. She will be speaking today about understanding chronic hypoxia and pre-existing injury. Dr. Jayashree, the floor is yours. Dr. Jayashree is online.
Yeah.
She's online.
Good evening, everybody. Thank you, Dr. Mosa. Thank you, Dr. Ahlam. And thank you, Sakia. Always, we don't get well oxygenated.
Dr. Jayashree, your screen is not shared. You
Sorry.
need to share, yes.
It is seen now?
No. You go to share screen.
I think maybe Dr. Shitra didn't stop sharing.
Maybe Dr. Chitra didn't stop sharing.
Now you can see?
No.
Dr.
Zakia, can you see what is the issue is? Maybe Jayashree, if you come out and join again.
You can join Aywa.
لا, the sharing screen is on, Doctor, for her.
On?
Yes.
But we cannot see it.
No, it's for her to use. Dr. Jayashree,
Yeah.
the green icon at the lower part of the screen.
Yeah, it is done already.
Can you check Zakia if Dr. Shitra stop sharing?
Doctor, nobody sharing except me. I was only sharing.
Can you stop sharing, Zakia?
I'm stop sharing, Doctor. Share. My screen is shared.
Try Dr. Jayashree again, please.
Once more.
Yeah.
Is it coming?
Did you press on share screen, Doctora? Press on share screen.
Okay, then I will go out and come once more.
Yes,
I think better, yes.
Zakia, can you let her join? Oh, okay.
Yes.
Yeah, Dr. Jayashree, you can again share your screen, please. Yes.
Yes.
Good.
Yes.
Yes.
Yeah.
So in labor, we always do not get well oxygenated, well-grown babies of healthy mothers always. We may get intrauterine growth restricted babies who is suffering from chronic hypoxia, macrosomic babies who may be suffering from relative uteroplacental insufficiency, as well as babies with fetal inflammatory response syndrome secondary to maternal chorioamnionitis, anemic babies, anomalous babies, babies with intrauterine viral infections with periventricular calcifications and neurological insult already, and babies with fetal arrhythmias and babies with antenatal stroke. Fetal monitoring in labor is actually aimed at prompt recognition of features of intrapartum hypoxic stress so that timely action could be taken to avoid poor perinatal outcome. Poor perinatal outcome, namely hypoxic ischemic encephalopathy, perinatal death, and cerebral palsy. But in spite of having the armamentarium of CTG in labor monitoring, we are not able to completely prevent all this poor perinatal outcome because it is not always due to intrapartum events. So placental vascular disease due to maternal medical illnesses or fetal infections can cause hypoxic pathway of fetal injury in the antenatal period itself. Like that, congenital or chromosomal abnormalities may lead on to intrauterine growth restriction, which again points to hypoxic pathway of antenatal insult. And there can be intrapartum events which produces acute hypoxia like abruption, cord prolapse, rupture uterus, and birth injuries can happen to the baby. All this can contribute to poor perinatal outcome. Fetal anemia, inflammatory response syndrome, fetal stroke, and congenital anomalies are non-hypoxic pathway of having poor perinatal outcome. So, by physiological interpretation of CTG in labor, we can distinguish between acute, subacute, and gradually evolving hypoxia. This we have already heard with Dr. Chitra. We can identify chronic hypoxia and pre-existing insults or non-hypoxic injuries also. So what is the benefit of understanding this chronic hypoxia and pre-existing injury? Because we can timely intervene and avoid or reduce fetal or neonatal acidosis. Acidosis is a surrogate marker for poor perinatal outcome. Why acidosis happens is already described. There is when there is hypoxia, there is anaerobic metabolism can happen towards the later part of it, and there is lack of energy to run cellular functions, leading to neuronal damage and myocardial depression. And CTG trace, as we know, is an interaction between the CNS and the heart. So it will show in the CTG tracing. So with this introduction, the objectives of our lecture is to discuss the difference between a healthy baby presenting in labor versus a baby with a pre-existing insult, either hypoxic or non-hypoxic, and the clinical implication of understanding the difference and how to recognize these antenatal insults using the CTG trace. Uterine contractions in labor is progressively increasing in frequency, strength, and duration. This results in repetitive umbilical cord compression and reduced uteroplacental perfusion. And this may potentiate the pre-existing damage or cause additional neurological damage in babies who are having an antenatal insult. And acidosis happens fast in babies with pre-existing insult. The rate of fall in the fetal pH will depend upon the individual reserve of the index fetus, the intensity and duration of the hypoxic stress, and any pre-existing or coexisting fetal pathologies. The normal values for umbilical cord gases is in the umbilical artery 7.18 to 7.38, umbilical vein 7.25 to 7.45, and partial carbon dioxide and base excess or base deficit will have to be looked at in the fetal pH, which we already heard from Dr. Badria. And this is how we analyze an arterial sample, umbilical arterial sample, whether the pH is less than 7.1. If it is above 7.1, we take it as no acidemia. If it is yes, look at the PCO2. If PCO2 is less, it is metabolic acidosis. If it is then if more than 74 millimeter mercury PCO2, if look at the base deficit. If the base deficit is more than 11 millimole per liter, it is mixed acidosis with the PCO2. And if less than 11 millimole per liter, it is respiratory acidosis. So with severe metabolic acidosis, when the pH is more than 12, there can be motor or cognitive deficits which can manifest later. That is one aspect of poor perinatal outcome. And in babies who are having an antenatal insult, this poor perinatal outcome is happens fast. So by identifying these CTG traces, we can optimize outcomes by avoiding the additional stress of labor to an already compromised fetus. And it helps to facilitate the counseling of parents regarding the guarded prognosis at admission to delivery suite itself. And this can, to an extent, reduce litigation also. So the common antenatal insults coming with CTG abnormalities are chronic hypoxia, anemia, infection, arrhythmias, pre-existing non-hypoxic brain injury, and fetal anomalies. A baby who is chronically hypoxic, that is, a placental insufficiency due to maternal medical diseases or due to placental insufficiency either due to maternal medical diseases or preeclampsia or any congenital or chromosomal anomalies. It initially shows reduced growth, Then redistribution of oxygenated blood to vital organs, that is the brain, heart, and adrenals, which is known as the brain sparing effect. This is what we pick up in Doppler evaluation. Then mother may complain of decreased fetal movement because baby will restrict the non-essential somatic movements, and fetal heart rate will be increased to obtain more oxygenated blood from the placenta. So a chronic hypoxic baby always can have a baseline fetal tachycardia. So this is again the pathophysiology. There is release of catecholamines. This will produce redistribution of blood from the fetal splanchnic circulation and peripheral vasoconstriction to the central organs. This is like an adult going in hemorrhagic shock. The same way the catecholamines are released and blood is redistributed to protect the essential organs. This will create an increase in the baseline fetal heart rate also, and the baby tries to metabolically adapt to the low oxygen environment. And when it is progressively worsening, development of acidosis happens, which occurs as shallow decelerations on the CTG. When there is cerebral decompensation, there is loss of baseline variability, and myocardial decompensation, progressive reduction in the baseline heart rate. So this is a CTG trace in chronic hypoxia. You can see a higher than normal baseline with very reduced variability and shallow decelerations. Sometimes this shallow deceleration it will not fulfill the guideline criteria of more than 15 beats drop per minute lasting 15 seconds, but it should be taken more seriously than that typical decelerations. This is a 41 weeks pregnant mother with 41 weeks pregnancy. This is the admission CTG. Here we can see the baseline fetal heart rate is around 160 to 170, which is definitely higher for a 41 weeks, and there is reduced variability and repeated shallow decelerations. So the pH in the umbilical artery at this stage itself will be in the mild acidotic range, 7 to 7.15. So if we allow this baby to progress with labor contractions, the CTG can become repeated decelerations, bradycardia, and fetal demise can happen. So the management in this type of this situation is immediate delivery by cesarean section, unless a spontaneous or operative vaginal delivery is imminent. That is, immediately we can deliver the baby by instrument, or you will have to deliver by cesarean section. Tocolytics such as terbutaline should be considered while preparing for delivery to avoid progressive myocardial decompensation secondary to ongoing uterine contractions. This was highlighted by Dr. Mosa in the discussion that when there is an abnormal CTG, by the time we shift the patient, we have to do the resuscitative measures such as changing position, IV fluid, stop if oxytocin is there, it has to be stopped, and if possible, tocolytics also to be given. The next chronic insult is anemia. Anemia can be either chronic, as in hemolytic disease of the newborn or parvovirus infection, or acute, as in feto-maternal hemorrhage or vasa previa. Chronic fetal anemia is a rare phenomenon in modern obstetrics because of the good antenatal care, and most fetuses with anemia are usually identified during ultrasound scan and treated in the antenatal period. This is a baby who is stillborn due to hydrox with parvovirus infection. And fetal anemia can present for the first time during the intrapartum period also. The CTG trace may show a sinusoidal heart rate, and the sinusoidal heart rate is formed because of the autonomic nervous system dysfunction combined with the increase in arginine vasopressin. So Modanlo and Freeman has described sinusoidal pattern as a stable baseline fetal heart of 120 to 160 beats per minute, the amplitude of 5 to 15 beats per minute, rarely it becomes greater, a frequency of 2 to 5 cycles per minute, fixed or flat short-term variability, and oscillation of the sinusoidal wave above and below the baseline. That is why it is called sinusoidal pattern. And no area of normal FHR variability or reactivity will be seen in these cases. So this is one case. The fetal heart rate tracing was recorded within 1 hour prior to delivery at a term gestation. The infant's Apgar scores were 0 at 1, 0 at 5, and 2 at 15 minutes of life. Even though the infant was ventilated, baby succumbed after 2 to 3 days. Possibly, this is a case of fetal-maternal hemorrhage. And this mother was admitted at 32 weeks gestation with sudden vaginal bleeding. Approximately 24 hours post-vaginal bleeding, this was the CTG recording of the baby, and a cesarean section was performed immediately with the appearance of the sinusoidal heart rate pattern. Soon after, the infant's hemoglobin and hematocrit were 3 gram and 9.1% respectively. This was a case of vasa previa. So a true sinusoidal heart rate is an ominous sign of fetal jeopardy needing immediate intervention. Fetal-maternal hemorrhage of more than 80 ml occurs in 1 in 1,000 deliveries and more than 150 ml in 1 in 5,000 deliveries. We may think 80 ml is a small volume, but for a term 3 kg baby, around 245 ml is its blood volume. So when it is 80 ml, it is almost 1/3 of the blood volume, creating hemorrhagic shock for the baby. And fetal-maternal hemorrhage accounts for 3.4% of intrauterine demise and 0.04% of all neonatal deaths. And pH of the umbilical artery is likely to show a mild acidosis in these cases. And if the fetus is exposed to further hypoxic stress, severe metabolic acidosis can happen. It has also been documented in several high-risk obstetric conditions such as diabetes, preeclampsia, amnionitis, and some fetal malformations also. This is the atypical sinusoidal pattern called pool shark teeth pattern. You can see the shark here. The teeth is like this, and this is the pattern of the CTG. It happens in acute hemorrhage like placental abruption, uterine rupture, rupture of vasa previa, and acute fetal-maternal hemorrhage. Umbilical artery pH may be normal with very low hemoglobin level if delivered immediately, unless if there is a delay in accomplishing delivery. This is also, it can also have severe metabolic acidosis. This is a trace which usually we may come across in labor ward, and most of the time we are worried when we see this type of a trace. But what is the difference between a true sinusoidal trace and a pseudo-sinusoidal CTG? Not the normal variability and acceleration before and after the sinusoidal pattern. And this does not normally exceed 30 minutes. This is not typically associated with fetal compromise, do not need any intervention, and seen in physiological conditions like rhythmic movements of the mouth such as thumb sucking or with the use of narcotic analgesics. This is another trace showing pseudo-sinusoidal pattern. You can see the normal variability and acceleration here. The next is chorioamnionitis. Inflammation secondary to infection can cause direct neurological injury and also acts synergistically with hypoxia to increase the risk of encephalopathy by up to 78-fold. Only minority of cases of chorioamnionitis will present with maternal pyrexia or tachycardia. Mostly we may have to pick up with the fetal tachycardia itself. And as earlier mentioned, individualize the baseline heart rate for a given fetus and use the same fetus as its own control. And comparison of a CTG trace with the previous trace may help to assess the normal baseline for a fetus in question. Also, lack of cycling has been recently shown to be associated with fetal infection. This is the zigzag pattern or saltatory pattern with increased variability. There is fetal tachycardia. It is starting to be having less variability, and there is uterine irritability. This is a CTG showing normal cycling. Many times with this strip, sisters are coming to us telling reduced variability, but if we wait for a little time, it becomes, it starts having normal variability and acceleration in a healthy fetus. This is called fetal cycling. So these are other traces showing tachycardia and reduced variability in chorioamnionitis. Infection itself alone can cause neurological damage, but if hypoxia happens together with infection, it can be potentiated. And other risk factors like growth restriction or meconium stain liquor is present, the damage is even more potentiated. So immediate delivery is recommended in this type of cases. As we discussed before, fetal CTG is an interaction between the brain and the heart. So fetal anomalies involving the brain or the heart will alter the fetal heart rate patterns even without a hypoxic or acidotic state. But no characteristic fetal heart rate pattern is related to specific heart defects. And in case of significant fetal arrhythmias, CTG might show specific patterns. Electronic fetal monitoring can give clues to an abnormal rhythm, but it is not diagnostic of the type of cardiac arrhythmia. There can be dropped beats, sharp downward spikes with the lowest point at about half the baseline rate. Premature beat with a compensatory pause. It will be sharp upward spike followed by immediately a downward spike. Bradycardia due to heart block, persistent and intermittent baseline rate that is half of normal. And sinus bradycardia is suspected if baseline rate is less than 110 beats per minute, but higher than half of the normal rate. This we sometimes find in labor. These are some of the CTG traces. Here we can see a CTG going heart rate here, then suddenly it drops to more than half the baseline rate, then again here, then again dropping down to the baseline rate. This is a case of fetal arrhythmia. And these CTGs we cannot keep for labor monitoring due to two reasons. One thing, it is difficult to monitor and predict acidosis with this type of CTG trace. And another thing, if such a fetus cannot further increase their heart rate to compensate for the stress of labor, and it may lead to rapid myocardial decompensation. So in this scenario, again, delivery by cesarean section is recommended. This is another case of arrhythmia where there is abrupt drop of fetal heart rate. It is not the typical U-shape, V-shape, or biphasic deceleration or variable deceleration. It is just abrupt drop of heart rate and then again going to the normal. So this is also a case of fetal arrhythmia. Then this is a case of fetal stroke. When there is a brain injury, the loss of variability is the hallmark of brain injury. So it can present with a CTG pattern similar to chronic hypoxia. Occasionally, when there is brain hemorrhage due to blood loss, sinusoidal pattern also is described. There are some other abnormalities like gastroschisis and intestinal volvulus, which can present with admission CTG abnormalities. In gastroschisis, 15% of babies may become intrauterine fetal death. The typical pathological finding is again reduced variability. So it has been debated whether factors other than hypoxia, like fluid and protein loss or pressure on the bowel, could contribute to the development of pathological CTG. Coming to intestinal volvulus, it is a rare life-threatening condition associated with fetal compromise. CTG shows reduced baseline variability with no accelerations. Most reported cases present in the early third trimester. Reduced fetal movements, static abdominal mass with dilated bowel loops is found in intestinal volvulus. Parasympathetic overactivity from the volvulus or fetal pain may be contributing to the CTG abnormalities. So this is a suggested fetal monitoring checklist to be used at the beginning of every CTG trace. Whether the baseline heart rate is appropriate for gestational age, whether there is normal variability and cycling, whether there is accelerations. If the patient is in labor, acceleration may not be seen, but there will be normal baseline appropriate for gestational age and good variability. There is no shallow or late deceleration, and consider a wider clinical picture like meconium, temperature, fetal growth, or reduced movements. This is for the admission trace. And overall impression, either we can take it normal or chronic hypoxia or any other finding. Then we can put a management plan, like this baby can be monitored or immediate decision to be taken. So to conclude, Recognizing chronic hypoxia and pre-existing injuries in CTG trace is important to timely intervene during labor management. To an extent, it helps in improving the outcome of an already compromised baby. And parents can be well informed of the clinical condition, prognosis, and possible neonatal interventions in advance, thus reducing litigation. Thank you.
Excellent.
Thank you, Dr. Gacy, for the excellent talk. I'm just seeing if there is any question posted. There is one question regarding the fetal scalp electrode. What is the advantage of fetal scalp electrode over abdominal probe? You can answer this question, Dr. Gacy?
Yeah, fetal scalp electrode is actually used only when we have difficulty in recording with the abdominal probe, like in maternal obesity or maternal multiple gestation, where one baby is monitored from the abdomen and the other baby, leading baby, will have to be monitored with the scalp electrode, so that we have clear tracing for both the babies. And fetal scalp electrode is not an answer for an abnormal CTG. When there is an abnormal CTG, well recorded by the abdominal probe, you should not waste time putting a scalp electrode and then monitoring that trace. If there is obesity, maternal movements due to pain, and cannot record abdominally, only fetal scalp electrode is indicated.
Yeah, I agree with you, Gacy, regarding the fetal scalp electrode. Fetal scalp electrode, if the abdominal trace show nicely the trace, and it is already abnormal trace, fetal scalp electrode, it will not reverse it to normal. So when it is abnormal, then it is abnormal. Fetal scalp electrode is not the solution for abnormal trace. It is only considered in case you cannot record the fetal trace by abdominal, either due to maternal habitus or because the mother, she is moving a lot because of the pain, or you cannot trace it by abdomen. There is two questions to Dr. Tamima regarding the guidelines, the national guidelines. I think Ministry of Health actually are in the process of revising the secondary care guidelines. And I think it will be, I mean, one of the guideline will be about the fetal monitoring in labor. And once it is done, I think it will be distributed to all the regional hospitals. And then there is another question regarding the need for certificate. And I agree with that. Since we have also certificate for BLS and ACLS, we should also have a certificate for CTG reading in labor, which may improve our skill, not only for the junior, but also even for the senior. We need to refresh our skill of reading and interpretation. In the setting of second stage CTG, how long we can wait before we intervene, cesarean or vacuum, given that it was a low risk pregnancy and fetus was normal? Dr. Gacy, can you answer this question? I mean, what she meant that you have a fetus, you have a mother who's in second stage, and it is already prolonged second stage, but the CTG was normal. For how long you will?
The CTG is going normal trace. For a primary gravida, you can wait up to 2 hours, and with epidural you can wait up to 3 hours maximum. For in a multi, it will be 1 hour and 2 hours and 1 hour. With epidural 2 hours, and without epidural 1 hour before we are interfering. But if the CTG is abnormal, depending upon the situation, anytime we may have to interfere in the labor.
And I think also we should look to the whole clinical scenario of the patient. If already you did ARM and there was meconium stained liquor, you don't want also to keep the baby in stress by prolonging the second stage. So look to the whole clinical picture of the patient. There is a question, Gayatri,
I have
about
written low risk pregnancy, and I thought it may be totally normal.
the issue, and that is very important point, Gayatri. The issue when we say low risk pregnancy, the mother may enter the labor as low risk.
Low risk, and then it become high risk in the course.
And this is one of the cases actually which it's important to highlight it, because one of the cases that reach the higher medical committee. A patient primary coming in labor, and she was primary low risk antenatally, and she was labeled for intermittent monitoring. But when she went into labor and they did ERM, it was big meconium, and they continues with intermittent monitoring. Of course, intermittent monitoring, it will not pick up all these suspicious chains. And with meconium starting in early labor, that baby came it was birth asphyxia. So we should be very careful when we label low risk pregnancy. Yes, she may enter as low risk pregnancy, but in labor she may have bleeding, she may have meconium state, her temperature may rise, she may have maternal tachycardia, which was not recognized with chorioamnitis. So we should be cautious with this. I don't like these things. The risk need to be re-evaluated even intrapartum. Regarding, there is one question regarding the fetal-maternal hemorrhage, Gayatri. When will you suspect fetal-maternal hemorrhage and how to recognize it?
Actually, I am not very sure how to recognize fetal-maternal hemorrhage antenatally. But when the mother has an antepartum bleeding, or anybody admitted with decreased fetal movements and all, we need to think about the fetal-maternal hemorrhage. CTG trace may give a clue, and fetal Dopplers may give a clue if there is middle cerebral artery dilatation and increased velocity in the middle cerebral artery. It may indicate fetal anemia. Otherwise, I'm not sure how to recognize antepartum fetal-maternal hemorrhage. And Cleover PET key count we can do in cases of APH. I think Dr. Mosa may be able to give a better answer regarding that.
No, I think I don't understand the question also. Maybe she meant in case of concealed fetal-maternal hemorrhage.
Yeah.
With CTG, if CTG, like what Dr. Gayatri have already mentioned, and she covered nicely the CTG chain that reflect if the fetus is anemic or not, you may, from the CTG point of view, you may suspect fetal-maternal hemorrhage, which may not be refilled, but that CTG chain, if persists, then yes, it can give rise. It can raise the suspicion of fetal-maternal hemorrhage. There is one question about any specific interpretation for monitoring of preterm before 28 weeks. Any specific interpretation for monitoring of preterm? Gayatri, can you answer this question?
Because fetal CNS shows this typical CTG patterns once it is getting more and more mature. So I don't think before 28 weeks we can go with CTG monitoring, but at least the baseline and variability we can know from the CTG trace once the baby is viable.
Yeah, it's a very good question actually. In preterm, especially before 28 weeks, we don't have that maturity of sympathetic and parasympathetic system, and the CTG interpretation before 28 weeks is very difficult. And this is why we should be very cautious when we read the CTG, unless of course there is deceleration. The variability will not be obvious in preterm baby, and the baseline also may show you tachycardia. It will be different interpretation compared with the term fetuses. There's a question from Bashir. I have read once that CTG monitoring increased the rate of cesarean section. Yes, Bashir, it increased the rate of cesarean section, and that is, of course, to avoid all these litigations. Nowadays, with any suspicious CTG, sometimes we don't want to take the risk, and then this is why the cesarean section have been increased. And this is not only in Oman, this is worldwide to avoid the risk of litigation and medico-legal complaints. I think that's it from the questions. Thank you, Geshe. Now, Ahlam will go to the next speakers.
Yes, we will go to the next speakers, yourself, Dr. Moza and Dr. Hind. So Dr. Moza is a senior consultant in obstetric and gynecology and fetal medicine at the Royal Hospital. She is also the founder and chairperson of the Oman Society of Ultrasound and Obstetric and Gynecology, and is the leader organizer of International Society of Ultrasound and Obstetric and Gynecology Outreach Program. Dr. Hind Al-Ismaili is a specialist in obstetric and gynecology working in every hospital. They will give us a lecture on interactive review of cases. Dr. Hind and Dr. Moza.
Thank you, Ahlam. Actually, the major talk will be run by Dr. Hind. And I'm requesting all the speakers to interact with the scenarios that it will be presented by Dr. Hind. It will be a conclusion or sum up to all the talk that we have heard. And also we would like also the interaction from the guest candidates as well. So Hind, you can go ahead.
Hind, go ahead.
Assalamu alaikum. Good evening, everyone. It's my honor to be part of this presentation today. Actually, this presentation will be about the interpretation of intrapartum CTG. So I will go through different scenarios, different CTG. We'll try to read that CTG and then see what proper action should be taken for each scenario. Yes. So started with the case 1. So we have a primary at 38 plus 3 weeks of gestation who came in early labor. During her vaginal examination, which was done 4 hours back, she was 2 cm dilated, 2 cm long cervix, 2 cm dilated os minus 2 station. And she doesn't have any past medical or surgical history. So before start reading the CTG, there are some few points I want to emphasize when we see a CTG. First, don't jump into conclusion that this is a reactive CTG. When we have a strip of a CTG, we have to confirm that this CTG is for the actual patient we are seeing. So there should be a sticker with the patient name, label, and the ID hospital number of the patient that we are really examining or seeing. So an ID should be here. Never accept any CTG without a label. And then the other thing we have to see also that there is a date of the CTG. When was it done? So this CTG was done on the 5th of October 2019. It was done exactly at 5:50 hours, and that 1 centimeter equal to 1 minute. These few things, basic thing, we have to make sure that it's there present before start reading the CTG. The component of CTG, I will try to start basic and then go on. So the component of the CTG, when we see it, here is the fetal heart rate, here is the fetal movement, and here should be the maternal pulse, should come also on the CTG, which is also valid and important to look at. And last is the uterine contraction. The other thing also, when we see a CTG, we should sign it actually that we did see the CTG, we comment on it, and if there is action taken, we should also document it. Sometimes we are in a hurry base in which, like, for example, it's a pathological CTG, I have to shift the patient immediately, so I should sign and write patient for emergency cesarean section. Because sometimes we are in a hurry, we have like a busy labor room, and then we forgot to write. This signature and the comment or action we wrote, or the advice we wrote in the CTG might save the patient and also save us. So on this CTG, if we go back, first CTG, I will read it, and then we'll try to make it more active. It should be more of an interaction between us. So the CTG, when we read, we say baseline. So the baseline actually is the mean fetal heart rate. Where is it exactly? So we draw like a line. It's not like drawing really a line, but we try to imagine a line in which most of the fetal heart will go through. So on this one, the baseline fetal heart is 130. It's almost 140, yes. So it is 140. So the baseline of the CTG is 140. And then we see, we should read the CTG systematic way. So we'll start with, as Dr. Tamima mentioned about the Dr. C. Bravado. So we have to determine the risk. So this patient is a primary, making the
Hind. Hind, your voice is not. Can you hear her, Dr. Moza? You're muted. Dr. Moza, you're muted.
Sorry.
Okay.
Yes, I didn't notice actually.
That's what I'm saying. Your voice, we cannot hear your voice. Okay. Yeah.
Okay.
Go on.
So I don't know where it has been actually stopped. So I was saying about this case.
Your lecture is not on Hind.
Just a minute.
Share your screen again.
Sure.
Or quit and log in again. Yeah. Okay.
Is it coming?
أيوة. Just share. So أيوة. Slide. Yeah.
Sorry for this. So yeah, so we were saying about when we read the CTG, so the patient is a primary. So once we say that the patient is a primary, she is a high risk. And then about the baseline, I was saying that we should determine, like we should try to draw a line in which most of the fetal heart would be on. So here the baseline of the CTG is 140. Variability. The variability is a changing of the fetal heart, as Dr. Ashitra mentioned previously, between 5 and 25 is the normal. So here the variability is good. There is like a change of the baseline. Actually, we should see it in 1 minute. Like in 1 minute, how was the change in the fetal heart rate?
Hind, your voice again. Hind. Dr. Moza, you're muted.
Hind, maybe if you change the place of your
صوتش مرة ثانية انقطع. No, you're not on. شوفي تو Hind. Okay, you're back. Yeah. Hind?
Yes, yes.
Okay, you're
sorry for this. Sorry. Okay. So we reach that acceleration are present and there is no deceleration. we shouldn't forget to see also the maternal pulse. The maternal pulse here almost like 80, which is normal, and to look for the uterine contraction. We shouldn't also forget to sign, and if there is any action we want to do, we should also document it in the CTG and in the computer in the system, as Dr. Tamima.
Maybe the maybe the connection. Yeah, Hind. Hind. Maybe you should change to a place with a better connection. Is she online, Hind? No, she's not. يمكن الكونكشن.
Maybe I will present I'm trying to see
the connection. Yeah, she's not on.
She needs to stop sharing.
It's not on the screen, Doctora. The Hind's screen is not shared at the moment.
Yeah. Okay. What I will do, I will try to share her presentation. Is it sharing?
Okay, Hind.
Sorry, I changed the place, and also I changed the Wi-Fi.
Okay, but
Sorry for this.
No, it's fine. It's fine. You can take it.
Yeah. So I was saying, overall impression for this CTG is reactive CTG. So should we do vaginal examination to the patient? Yes, because last vaginal examination was 4 hours back and want to know the progress of labor for this patient. And oxygen by face mask, no, there is no reactive CTG. Should we wait? Yes, we should wait for the progress of labor. So this patient, she progressed smoothly and delivered vaginally to a baby boy after 5 hours with a weight 2.7 kg and good Apgar with a cord pH is good also. So when we were like talking about cord pH, just a few points I will try to again speak about it, already mentioned in the previous slides and previous talk. So cord pH, we have arterial and we have venous cord pH. For the arterial cord pH, it reflects the fetal acid-base status. And the venous cord pH, actually, it reflects the maternal acid-base status and the placental function. So both cord pH, the arterial and the venous, they are both important. The ideal situation, as Dr. Tamima said, that we should have both of them. If it is difficult to get both, at least the arterial one. And if we collect a cord pH, we should mention which one is it. Like in this case, I should say that this cord pH is arterial, for example, which will make a sense. So case 2.
Can I go ahead, Hind, with reading CTG?
Auspicious. Okay, so interaction, if anyone from the audience can read the CTG, please. So case 2 for a 31 years old patient who is gravidat 2 para 1 at 41 weeks of gestation, admitted in active labor. So that it was an effaced cervix, 8 -1 station, and meconium stained lacquer draining. The CTG.
You can go ahead, Hind, with your next slide.
Okay. So for this CTG, as previously, Dr. about the parasympathetic and the maturity of the parasympathetic system and fetus. So this case, the patient is already post-date. She is 41 weeks of gestation. So having a baseline of 160.
I think, Hind, your voice is not that.
It's not clear.
Not clear.
The connection is not that good, I think, Hind.
Hello?
Yes, we can hear you. So till Hind join, so this is a 41 weeks, which is post-date. You can see that for post-date, we have said that the baseline should be lower than 150, but you already see that the baseline is more than 150, which is almost 160. And the patient, she started with meconium stained lacquer. She's, yes, HCM dilated, but you can see that there is decelerations, U-shaped decelerations, variable decelerations. And the variability, when the patient recovers from the deceleration, there is a reduced beat-to-beat variability. You can go ahead, Hind, with the next slide.
Yes, sure. So am I audible now? Hello?
Yes, you are. Your voice
Hello?
Just
Yes.
go to the next slide.
Yes, sure. So this CTG was, as Dr. Moza mentioned, it's showing that fetal tachycardia variability. So should we wait for 30 minutes and then review the patient back? No. Change the position of the patient. Yes, it can help, but talk to the patient while seeing the CTG, because the mother will get worried. So the patient had cesarean section, and she delivered a baby girl with the weight 3.8 kg with a GAR 1 and 5 aspiration and
Hind, I think it's better if you just show the slides. Your voice is not clear at all.
So
It slows down, yani.
going to the third case, we have 21 years.
Hind, do you hear us? So, Hind.
Yes.
Can you go back to the previous? Can you go back to the previous slide? And what we will do, I will try to go through the slide and just change the slide.
Yes,
Okay?
Victoria.
Because your voice is not that clear. So I'll go through the slide. You just change the slide from your side. هند شكلها عبري ما فيها تغطية. يا هند.
Yes. Okay, sorry. Yeah.
Hind, can you go back to the previous patient?
Sure.
This is very important presentation, and we are really sorry because of this internet issue. You just bear with us. Can you go back to the previous case?
Yes, sure.
Can you go to case 2, please?
Yes.
Okay, and can you go to the next slide? Yes, so this baby is, or this fetus already decompensated. And if we try to resuscitate the baby before taking for cesarean section by changing the position, you can see that still the baby is not responding. So this baby needs immediate cesarean section because already CT is showing decompensation and the baby is not compensating with the after the decelerations. So cesarean section was done for this patient, and it was a baby girl with a good size baby. And the APGAR, you can see that the APGAR is already low score. APGAR is 1 at 5 and 5, and the core pH already showing acidosis. The baby had meconium aspiration, which is expected. And the issue that when there's already meconium and then you put the baby in distress, then of course one of the complications will be meconium aspiration. And this is why very important when you have such CTG with background of meconium stained lighter, not to wait for 30 minutes. Immediately you have to go to this patient for cesarean section, because I think even with resuscitation, this baby will end with a poor outcome. Next slide, Hind.
Yes.
Next slide.
Hind. Move to the next slide, Hind. Case number 3.
Hind, what we can do, you stop sharing and then I will present. Yeah, Hind.
Well, I'll call her. Okay, thank you. Okay, Dr. Musa. Okay.
Okay.
You stop sharing.
أيوة دكتورة, she stopped sharing.
Okay. Do you see my presentation? The presentation.
Yes.
Okay, so we'll go to case
3.
Yeah. So this is 21 years old gynae patient complaining of reduced fetal movement. She was at 42 weeks of gestation post-baby. And when she was admitted, Just to remove this. Sorry. When she was admitted, the cervix was 1 cm long, was 3 cm minus 2, and they did amnio ARM, and it was, the lighter was clear. So they started her on Cinto, and this is the CTG status, which was reactive trace with baseline of 100, between 140 to 100, almost like 150 with good variability. And then just concentrate on the uterine contractions. You can see that in the uterine contraction part, you can see there is some element of hyperstimulation. So how to act? CTG was okay. So you will not just observe. What you can do is, of course, you have to reduce the syntocinon infusion rate. No need for cesarean section because the CTG trace is reactive. But you can resuscitate by giving oxygen. And after reducing the syntocinon infusion, the contractility came to the normal, and the patient progressed into normal vaginal delivery with normal outcome. So it's important not only to concentrate on the fetal heart, but also you have to look to the uterine contractions. This is another patient who is 28 years old, grafted 5 parapose, was 39 weeks, and she was admitted in labor. Her blood group was O positive, and antibody screen shows negative screening. But this is the trace. And you can see what has been mentioned by Dr. Deshi, the baseline with sinusoidal pattern. So do you observe and review after 1 hour? Of course, no. You will do fetal blood sampling if feasible for coach pH. I don't think I agree with this. Do we do fetal blood sampling if feasible for hematocrit and hemoglobin? Yes, but the patient is already in labor. Why we do this? Why we waste the time? Immediate cesarean section? Yes, we should do immediate cesarean section. So I don't agree with fetal blood sampling, and I don't agree with fetal blood sampling for hematocrit and hemoglobin. This is require immediate cesarean section. And cesarean section was performed due to fetal distress, and the outcome was baby girl waiting 960. You can see she was 39 weeks, severe IUGR with Apgar 1 and 6 and 1 at 5 minutes. Severe IUGR, and umbilical cord was 7.3 and venous 7.4, and the infant had intracranial intracerebral hemorrhage and died after 5 days. So this is one of the causes of fetal anemia, severe IUGR, sinusoidal pattern. This is another patient. This is 21 years old, dryly gravid patient who was admitted in labor at 40 weeks. And VE shown cervix fully dilated at +1, fully effaced. Oxytocin ongoing. So it is already second stage cesarean, second stage. And you can see that the fetus spending more time in deceleration. And you can see that there is loss of variability. So this patient needs to be delivered. And since she is already in second stage, then the delivery will be by vacuum or instrumental delivery. We'll observe, of course, we will not observe. This patient needs to be delivered. Reduce the rate of syntocinon. Yes, we can resuscitate this fetus by reducing the syntocinon. You examine, she's already examined and she's already in second stage. Cesarean section, even if delivery is imminent, no, this is for vacuum delivery. And this patient, she progressed actually to normal vaginal delivery. And the baby was 3 kg, Apgar score 3 at 9 and 1 at 5, 3 and 9 at 1 and 5 minutes. And it was meconium, required tracheal suction. And there was 1 knuckle cord and 10% placental separation. And then the infant had a normal newborn course. This is another case, 21 years old, Brian patient admitted in labor at 40 weeks of gestation. You can see the CTG with normal baseline, normal acceleration present, good variability. And the contractions, if you count the contraction also acceptable. So it is a reactive CTG case. So you will observe for progress of labor. No need to do fetal resuscitation, no need for the fetal blood sampling. And this patient, she progressed into normal delivery and had normal outcome. This is 27 years old, gravida 4, bara 3, who was also post-date, admitted in labor. And 15 minutes prior to this recording, VE was done and it was 8 cm dilated, fully effaced surface, vertex at -1, and ARM done and it was clear like that. And you can see that there is sharp, quick early deceleration. So for early decelerations, yes, I mean, no need to do the resuscitation with oxygen or change maternal position. No need for cesarean, but just to observe for the progress of labor. And this patient, she progressed to normal vaginal delivery and she had good outcome. This is another CTG, which is actually, we have a lot of such CTG when coming to the higher medical committee. And this is 21 years old, Brian, admitted at term. And she was already fully dilated, cervix fully effaced +1, and it was right occipital anterior moderate meconium. And you can see that there is, I would say this is more of variable decelerations, but there is, there is fetal response with tachycardia. You can see the tachycardia. She's already in second stage, not for syntocinon because she was getting good contractions, but you can deliver this patient with instrumental delivery. And this patient actually, she progressed into normal vaginal delivery, 3.3 kg, Algar 7 and 9. And the baby has normal outcome. Sometimes the obstetrician may misinterpret this CTG as expected second stage CTG. And if the patient, for example, the head is at -1, they will wait for this patient to either the head come down or for them to have either normal delivery or vacuum. But actually, if the CTG persists like that, then we are expecting poor outcome for this baby if not delivered by vacuum or delivery is not imminent or not taken for cesarean section. So this is not second stage expected CTG. This is suspicious CTG. Action need to be taken either to deliver by vacuum or if delivery is not for vacuum, then to take her for cesarean section. So this is 35 years old patient, gravida 7, bara 6. She was also post-date in labor. The vaginal examination, she was still in first stage of labor and the head at -2, but the lighter was meconium stain. And you can see the CTG with decelerations. It is more of, I would say, variable deceleration, and the baseline was 140. But you can see that there is compensation from the baby side lacking. The issue here that with compensation, there is reduced variability. So I will not wait for this. I will take her for cesarean section because she's still in early labor. Yeah, and there's already meconium stain like her. With such CTG, I will not put one more stress on this baby to end with meconium aspiration and then birth asphyxia. So I take her for cesarean section. Yeah. Till we prepare for the patient for cesarean, we can resuscitate the baby by changing the position, by giving oxygen. And the outcome was male baby, 3 kg. Abgar, you can see that the Abgar was low at 1 minute. And this baby had meconium aspiration. You can see even if you wait, it will be more bad outcome. This is typical case. 30 years old, grade 4, bara 3, was admitted in labor at 36 weeks. She had history of cesarean section in her second delivery. And 1 hour prior to this trace, the os was HCM dilated and clear like a was draining. But you can see suddenly there was bradycardia. And with that bradycardia, there was no recovery. So vaginal examination done, check maternal spital signs, mother was tachycardic. Cesarean section, patient was taken immediately for cesarean section because there was no recovery from the birth and it was ruptured uterus. So this patient had ruptured uterus. There was complete scar dehiscence and the infant was in the peritoneal cavity. It was male baby and fresh stillbirth. This is 37 years old, grade 6, para 5, 39 weeks, fetus cesarean. She came in active labor and examination shows fully effaced cervix, 9 cm minus 2 station. Membrane were absent and she was getting good contraction. But you can see that the baseline is not that clear, yes? There is in between decelerations and then tachycardia. So examination done for this patient and cesarean patient posted for cesarean section and she was taken for emergency cesarean section in second stage and during cesarean it was found to be ruptured uterus. You can see this is another case scenario that may suspect or give you suspicion that this CTG, that this patient might have ruptured uterus. The baseline is not clear. And there is already a shift in the baseline from normal baseline to bradycardia and then tachycardia. It's not that clear whether this is maternal, whether this is fetus. Such cases, better to take them for cesarean section. This is a twin, MCDA. This is another twin trace. So when you have twin with mirror image CTG, you continue observation for uncomplicated twin. This patient, she had cesarean section as planned and it was first twin macerated stillbirth, 1.6, second twin was male, 2.6 kg. Actually, this is the same trace of the same baby. And you can see that mirror image trace. So you should be careful when you integrate the CTG, especially in twin pregnancy. This is case 14. She was drawing multi 38 weeks, presented in early labor, and she was in early labor, high presenting part, AR and done. And you can see there is sudden shift in the baseline. This is another case where you have a patient post-date. She was admitted for induction of labor, and this is the CTG post-protein. You can see that there is deceleration, unprovoked deceleration. So what you will do? So unprovoked deceleration, there is reduction in fetal heart rate by more than 40 beats in the absence of uterine contractions. So when you have such cases, if with resuscitation the baby is not recovering, then of course you have to take action for delivery of this patient babies. I will not go through this because it was already covered by my colleagues. Thank you. And I think it is the time for questions. We already passed the time. Any questions in the books? I think there is no more questions.
There are no new questions, Doctor.
There is?
I don't see any new questions. So certificate.
So if there is not any more question, I think we will end the webinar session. Do you see any questions?
No, nothing new. Last one was, nothing. At least
Okay,
not.
so I think it is the time to end the webinar sessions. Any feedback from the speakers? Dr. Gayatri, Dr. Tamima, Dr. Hind? Any questions, any feedback from your side?
Thank you.
Okay,
No,
I
thank
think,
you, Moza. Thank you for the organization of this webinar. We should do it more frequent. Thank you so much.
Thank you, dear Tamima. I think I would like to thank all the speakers for their participation, especially during the weekend as well. I would like to thank all those who attended the webinar, and I hope you get benefit from all the talks. And sorry for this connection issue, and sorry, Hind, for the issue of these connections. I understand that you are on call, but I'm really thankful that you could tried hardly actually to join us. So thank you all. Thank you.
Thank you.
Thank you, Dr. Thank you.